3 minutes and then we can start.
Ben YouTube'u da başlattım şu anda.
Tamam. Bir dakika sonra açalım Emre.
Oradan da izleyenler var şu anda.
Evet, saat 20 bence başlayabiliriz. YouTube açık mı Recai Bey?
Evet, yayın açık.
Okay. Good evening for everybody. Tonight we have another webinar of our society. The topic is robotic liver surgery. Professor Momeo, on behalf of the Turkish Association for Endoscopic and Laparoscopic Surgery, I would like to thank for your accepting our invitation and also sharing your experiences with us. Dr. Emre Bozkurt is going to moderate the session. I wish all the participants a very pleasant webinar tonight. It's your turn, Emre.
Thank you. Good evening, everyone, and welcome to the webinar of the National Association for Endoscopic Laparoscopic Surgery. We are excited to launch this webinar, which aims to bring together experts to discuss the latest advancements, challenges, and innovations in our field. Through this webinar, we hope to foster knowledge exchange, collaboration, and meaningful discussions that will contribute to both clinical practice and research. Thank you all for joining us, and we look forward to an engaging session. First, I would like to express my sincere gratitude to Professor Ricardo Memeo for accepting our invitation and joining us today as our speaker, and it's my pleasure to introduce him. Professor Memeo is Professor of Surgery in Lund University in Bari and serves as the Director of Hepatobiliary, Pancreatic, Minimally Invasive and Robotic Surgery at Miele Hospital di Acquaviva della Fonte. In this session, he will be sharing insights on two highly relevant topics in the field. After each topic, we will have 10 minutes for discussion and questions, and I encourage you to actively participate by typing your questions in the chat box at any time. Yes, Professor Memeo, the first talk is tips and tricks for managing emergent or urgent situations during robotic liver surgery and added value of ICG usage. Yes, please.
So, good evening, everybody. I'm extremely happy to be here because it's for me extremely important to share opinion and knowledge about the use of minimal invasive surgery and robotic surgery. We are going to speak about what is actually the role for me and the position of robotic surgery. Speaking about different topics during our discussion. One, for example, of the main situation that we should speak about is the fact that we are facing now the emerging position of new platform of robotic, and it is very important because we have to understand which is for me the real place of this platform. So first of all, I think it's mandatory to understand how we can imagine which is the place of the robot. First of all, now we are in the era of XI robot, that is one of the most diffuse robot, and with robot we can think to have some advantages compared to laparoscopic surgery. I think, in my opinion, that we have a reduction of difficulties of the operation, meaning that in my team I see that the learning curve, for example, is shorter with robotic platform, considering the fact that we have also data from literature that are confirming the fact that we have less complication, a shorter length of stay, a lower rate of conversion compared to laparoscopy, and a reduction of postoperative bleeding. One of the other important aspects is the enhanced visualization and management of what are actually considered the most important anatomical landmarks. There is the possibility to flip the camera, is also the pain management, especially compared to open surgery, and the concept of enhanced docking process that allow to have a better anesthesia. In my opinion, it's also very important that in some aspect of complex surgery, if we speak about, for example, complex liver surgery cases and complex pancreatic surgery cases, we have some advantages, especially in the part of the reconstruction. For example, if we have a demolition part of the surgery that can be performed equally maybe with the laparoscopy, in some cases, for example, hilar dissection, lymphadenectomy, we have some advantages, technical advantages, and we will see some video later. So it's very important to understand which is my journey in different surgical approaches of liver surgery. We are, I think, in a moment in which we should not avoid to learn open surgery. It's mandatory, it's important because it gives us the main concept of oncological surgery. Liver transplant has an important role also in the knowledge of which is the possibility to have with open surgery. And in my opinion, one of the most important things was for me organ procurement and the possibility to manage with bleeding and the possibility to have a bleeding control. What I learned from laparoscopic surgery is the advantage of liver minimal invasive liver surgery approach and the possibility to give a patient benefit. Meaning a patient benefit, I mean, and I want to say that it's very important, for example, to have this kind of advantages for the patient of minimal invasive access. Robotic surgery added some important opinion, for example, about the vision, the reproducibility of the gesture. As I told before, it's very important for young surgeons to have the possibility to work in double console. The teachability is easier, and I think it's a sort of democratization of surgery. What I assist now and what I see now in the Italian community of HPB surgeons, that even more centers, also low volume center, approach liver surgery easier than approaching laparoscopic surgery. So in my opinion, it's very important to understand that we need a progressive learning curve. We need to start. It's very, very important to start to assist, to be the first assistant at the table, then to pass to single case, to simple cases, then to teach and then to understand and to train on the simulator and the platform and with first cases to complete the HPB experience with complex cases, being now an proctor for Da Vinci. And last week we performed our first two liver resection with the single port surgery. So it's very important to find the place of what is now robotic surgery. I think that new generation can jump without the necessity to have a complete complete learning curve on the laparoscopic surgery. What I mean in these cases, for example, if you see with this article published by the group of Troisi, it speaks very well how we can reproduce in in robotic surgery some gesture typical of the open approach, meaning the pedicle dissection, the arancular ligament section, biliary section, Gleasonian approach, bile duct exploration, hepaticojejunostomy, and all complex pancreatic surgery. But the most important thing is consider what is the place of the robot. If we see data in literature, for example, the serial described by Matthew Don't, you can see an important data. If you see data from 2012, we have the comparison of open and laparoscopic surgery. We have an increased number of cases of laparoscopic surgery in the sequel years, up to be completely put in relation with the role of robotic surgery. If you see in 2020, which are the data from this Center of Matthew Don, you see that open surgery still have a role, but open surgery was little by little substituted by laparoscope by robotic approach. This is data of our center, meaning that we start with an initial experience with, for example, a case distribution of 70% of laparoscopic cases of liver surgery. Then we move to the plateau of completely all cases performed by robotic surgery. And if you saw in the lower part, we have an increased difficulty of cases performed by robotic surgery. So we have a phase of transition, a phase of consolidation of robotic experience, and a phase of optimization. If we see the data in literature comparing hepatectomy and comparing open hepatectomy and minimal invasive and robotic hepatectomy, we have a reduced operative time in open surgery, but we have to face this with a reduced rate of blood loss in minimal invasive surgery, reduce the rate of transfusion. Major hepatectomy were even more favored by robotic approach due to the rate of postoperative complication, even if also, for example, we can see that in posterior section, in posterior sector, so in complex cases, we have an advantage for patient with robotic surgery. And the rate of R0 resection was similar with both approach, with a reduction in rate of DINDO 3 and 4 complication, of general complication, and about mortality, with a total cost that was little by little increased by robotic surgery. What is extremely important is reduction of what is the reason for the learning curve of robotic surgery. As you can see, if we compare the interrupted line in the upper part and also in the other second graph, you can see how the blue line, the continued blue line, represents the operative time of surgery, comparing laparoscopic surgery and robotic surgery. So you can easily understand that it's easier to learn with robotic surgery. It is very important, for example, with this score of SUCAMD, of the Tampa score for robotic surgery, we can choose and we can identify simple cases in order to have what we can call a progressive learning curve performed at the beginning of the experience with simple cases. We describe at least 40 cases, so not so much cases, an intermediate phase of about 200 cases, and then we move to more complex cases. One of the most discussed point is the fact that robotic has some costs that are increased compared with the robotic, with the laparoscopic and open surgery. But as you can see, it's very, very important to understand that we have a sort of reduction of costs in the final part with the reduction of hospitalization. And it is very important to understand this, to understand the value of the robotic platform. If we speak about robotic surgery, we should identify one of the most important things is the port placement, because if we are not good in port placement, we can have some problems. So, for example, we have at the beginning of the surgery, we have to plan our surgery, to plan our liver resection, either with 3D reconstruction and either with actually tools that now that we have for this kind of situation. So, for example, with 3D reconstruction or also with CT scan and MRI, we have to adapt our planification to the body of the patient and to the fact that maybe it could be previously operated. And it is very important because we have some necessity to put and to adapt to surgery. But for example, as you can see in this video, in this photo, previous open surgery is not a contraindication, for example, in the realization of surgery. The operating theater should be usually settled for a robotic platform. We can have different robotic platform. For example, we have the most diffuse maybe is the Da Vinci Xi up to now, but we have also UGU or Versir or CMR that are in market now. So we have to standardize the position of patient, the position of assistant, the position of the double console, and it is very important to train your anesthesiological group and at the same time training your nurse. If it's possible to have also always the same assistant and nurses, and at the same time the anesthesiologist is very important. And another aspect that I found, in my opinion, it was very important is the standardization of the of surgery. We have to explain, for example, to all the group that we have also the same step for surgery in order that everyone could study and could understand how to afford this kind of situation. Patient positioning is important. We can be in American position or in French position. It depends on which kind of surgery and which kind of server we have. Up to now, we use always this modified Lloyd Davis position with the lower part of the legs and assistance diagram among the leg of the patient. There are some necessity of move the patient, not when the robot is connected to the patient, but before, and it could be very important. Some cases we use left lateral decubitus, but we reduce the age of this case because of the kind of surgery. This is our preferred position, is a modified French position with sternum on the leg and with a little rotation if we have posterior segment. One of the main concepts which we stress on, that the results very important in the conception of democratization of surgery, is that when we use laparoscopic approach, we are obliged to use some axis of action. When we use a robotic approach, we can modify and we can adapt to the surgery. One of the ways concept is the target of the camera. And so it is very important because we do not have to be too far, neither too close. And we have to put the working line almost 5 or 10 centimeters above the umbilicus, for example, for liver surgery. And we should adapt to be at the correct distance in case we have obese patient or we have shorter patients. So it's very, very important. We use two kinds of setting for robotic port. We have a left segment with left lateral sectionectomy, for example, in which we have the robotic port on the umbilicus for the camera. And then we have two arms on the left part and one arm on the right part. All other segments are exactly the opposite. As you can see here, left segment in that way, all the other liver segment in the same symmetric distribution. The orange dot are the assistants. We used to work with two assistants. When you perform complex liver surgery, it's very important to have very good assistant at the table. And for example, if we need to have an lymphadenectomy or a right hepatectomy, like in this case, we have to move a little bit lower to have the possibility to complete the lymphadenectomy. Specimen extraction in most of cases is by fine steel incision. Otherwise, if we have a small resection, we can have, as for example, in last single port with the port with an enlargement of one of the robotic ports. Another aspect is we did not use the RCL due to air embolism during surgery, and we always use intracorporeal Pringle. It is very important because, as you can see, it allows us with the 16 French urinary catheter to have the complete control of the hepatic hilum. We pass beneath the hepatic hilum. We have this catheter going through, and it is very, very important because it allows to have a control of the hepatic hilum during liver resection. We use a clamp in case of bleeding. In some cases, we prefer to use this kind of attention also in patients with low bleeding, but it could be very, very important. We will see later with the double bipolar technique that we have described recently, that it would be extremely important to have this kind of clear field. We can have also extracorporeal Pringle maneuver also in robotic, but I think it's easier to reduce the number of things to do to the assistant. So it's very, very important to have this kind of approach in intra-abdominal. Intraoperative ultrasound is mandatory. Liver surgery now needs this kind of approach, and it's very, very important. You can see there are different kinds of probes, and it's very, very nice to have a very long ultrasonic analysis of the liver to discover, as you can see, for example, in the use of ICG in the right part, to achieve correct margin using ICG and mixing it with the use and with the knowledge of intraoperative ultrasound. It's very important to know that, for example, one of the most important gestures is the rotation of the liver. One of the most important things, for example, is the mobilization of the liver. As you can see, with the fourth arm, we are lifting up the liver, and we will see better when we will see the case of the Klatskin tumor. And all this mobilization is very, very important because it allows us to rotate the liver and to have in the front part the posterior segment and to have complex cases. One of the things that I love of robotic is what I call the fourth arm effect, meaning we operate with two arms, but we have, as you can see with this one, the possibility to divide and to move with the harmonic sealer. We have the possibility to have something like an X position and to invert arm 3 and 4 to have this kind of a thing. So it's very, very important what I told you before in the use of ICG, in the use of robotic. ICG is used to identify the limit of the anatomical limit of our resection. How it works? It works with the injection. Once that we have clamped, for example, in the central hepatectomy, we clamp the pedicle for segment 5 and 8. We clamp the pedicle. We inject in vein the androgen green, and we can have negative staining. And so the part to resect is the one that is darker. We can have some different. We can have some kind of help to have a better retraction. We can have some traction made from the external part in order to have a better transaction and a better traction. And it's very, very important to do this. One of the things that we saw, especially for example, in Whipple procedure, is the necessity that we have to fix, for example, the gallbladder or the round ligament in order to have this kind of traction. And it's very, very important because it allows to have a free fourth arm to complete the surgery. Also, another thing is another thing. I think that one of the most important concepts in robotic is, for example, the fact that we have the difficulty of cases is increased in order of the kind of transaction line. If we have a straight transaction line, it could be extremely useful to have this kind of approach. If you have curved line, it could be a little bit more complex to keep the correct margin. And so we will see later in a video. Another thing that we have to face is the difference about the possibility to have nice work in a clean field. You see the middle hepatic vein in normal liver. Another thing that could be extremely complex is the necessity to work, for example, with big tumor of segment 8 in cirrhotic liver. You see the difference. And so you see that's how it's very, very important to have this kind of contact with the vein. But I assure you that it's possible to do, but you need to be extremely safe and with the progression. Another thing that we can do, for example, in robotic surgery is to control the vein. As you see, we did not need any CUSA or ultrasonic device. In this case, on the right part, we have a dissection of a resection of adenoma in the middle of the liver. In the right part, you saw the possibility to have an R1 vascular resection, completely detaching from the liver all the structure. So it's very important. I think that we do not need any CUSA to perform to be in contact with the vein or in contact with the vena cava. We can have dissection of the hepatic hilum, extraglyconian dissection of the hepatic hilum, as you can see here. We have an extra dissection of the hilum. We put on the clamp to check if vessel is okay. And you can see we can have extraglyconian and interglyconian. And ICG, we can have the demarcation, and it's very, very important. In the green part, we have the part that is vascularized. And here we have, for example, in a right hepatectomy, you see the lesion below the middle hepatic vein. We can have this kind of resection. No problem. For example, this is the right hepatic vein. This is the vena cava on a big hepatectomy for a giant idiatic cyst. We can have the control of the right hepatic vein. We can go directly straight on the vena cava, or we can, with the use of this sector, we used to use a tape in order to have the possibility to encircle the vein, and then we use either robotic or this taper in order to complete the resection. We have this kind of technique, we have an isolation, and then we use some stitches to control the vein. Here you can see the middle hepatic vein and the origin of the left vein in this kind of hepatectomy. So it's very, very important to go closer to the vein in order to achieve this, which is the limit up to now, but I think it's overpassed, is the fact that we have up to now only energy device and vessel sealer, or the new one that is available to have the parenchymal transection, the synchroseal. But it's very, very important for me, comparing to other techniques that use ultrasonic dissection, to have Kelly-Clash clamping technique to complete the liver resection. This is a double way to perform. This is the courtesy of Professor Aldrighetti with CUSA, and this is the way we perform without CUSA the major hepatectomy. So I think it's very, very important to have to know the tool that we have. In the left part, you see the synchroseal that is used in some surgery. in the right part, we have the use of the vessel sealer, and it's very, very important to achieve the goal to have a bloodless transection line. Thank you very much.
Thank you, Professor, for your explanatory and excellent speech.
If you have any question, I'm here for you.
Okay. There are some questions from audience and also from YouTube. Uh, what do you think that how does robotic platform enhance the management of intraoperative complications like bleeding or bile duct injuries?
I think that in control of bleeding, it's very, very important because if we use, for example, the Kelklesia technique with the double use of the energy, we have the possibility to control the bleeding and to see big vessel. In case we have a big vessel injury, we should always be ready with clamping technique, and on the other hand, we should have the reflex to have to be focused on the fact that we have three arms. So with one arm, for example, we can clamp the lesion of the vein using, for example, forceps, a bipolar forceps of a Cadier we clamp, and with the other two hands, while the assistant with the suction try to show us the origin of the bleeding, we can suture. So personally, I think that it's very, very important because we move the camera, we know exactly where we want to see. The assistants help us with suction and irrigation, and so it's an easier way to control the bleeding, either in liver surgery and especially in um, pancreatic surgery, where we can have more extreme bleeding, for example, as we have on the superior mesenteric artery on most branches coming from there.
Okay, thank you.
And just another thing, in any kind of surgery that we have, one of the key part is to be always in thinking that we have an emergency conversion. So, for example, all the instruments of open surgery should be in the operating theater on the surgical table. So we always have all the tools for conversion ready on the table while we perform robotic surgery.
Also, the next question was the thing that you already explained, that what is the best course of action for an emergent conversion during robotic surgery?
So, first of all, we should control the bleeding or reduce the bleeding. So if we have, for example, a venous bleeding from a vein, we can, in the worst of the situation, have a sort of packing with gauze and arrive to conversion. We can leave someone having the pressure on the gauze, and we can have this kind of conversion. Otherwise, if it's not possible to control like this, we have to reduce the bleeding with something like a stitches, also with a stenotic stitches before the conversion. It's difficult to have a conversion with an open bleeding, and it could be extremely dangerous because the time of conversion would be quite long. So we can, for example, leave one of the robotic arm clamped while we remove the robot and we prepare for conversion. It's something like we should learn at the beginning of our experience. They teach us that we can leave one of the robot in compression, of the arm of the robot in compression while we convert, and then we remove this part of the robot and we go with the open surgery.
Emre says sound is
Yeah,
off.
I think this is the most important thing, that before conversion, control bleeding.
exactly.
Okay, there is one more question from audience, that how can artificial intelligence help with robotic surgery?
I don't
What
understand.
what do you think about artificial intelligence, the implementation of artificial intelligence in robotic surgery? How can it help to robotic surgery or robot-assisted
So
surgery?
I think that robotic surgery up to now is something that has an important value in learning of surgery. So I mean, it's easier to operate with robot if you have a good proctor or you have a professor, someone who teach you to learn faster than laparoscopic surgery. But now we are using 10% of the potential use of the robot because most of the improved thing that we could do will come from augmented reality, from virtual reality, from artificial intelligence. That I think that could be something that could be implemented with robotic surgery. If you see the new robot, the fifth, the Da Vinci 5, something like that, it's exactly the same robot. It seems something like similar, not nothing was changed. That's for arms all the same. But what they do, they have an enormous working and implementation of the software of the robot because they prepare to the arrival of artificial intelligence and augmented reality. They say that was the machine should be ready to speak with this kind of tool and to integrate with this kind of technology.
Okay, thank you. Also, you present a single port DaVinci SP as a tomorrow in your presentation, but I think you today you already performed your first robotic DaVinci SP liver surgery. Uh,
Yes,
what
we
do you think?
performed.
What do you think on DaVinci SP? Why is it important?
So I think that we have to perform simple cases, or the simple cases meaning we have a small gallbladder cancer with small liver resection, and then we had something like cyst, hepatic cyst fenestration. So the first two cases were simple cases. We are programming now left lateral sectionectomy or segment 4 liver resection. So this is what we plan. One of the most important concepts of the single port is the fact that your surgical field would be maximum the size of an orange. So I think that it could be extremely useful in some small resection of the liver. I did not see any advantages of major liver resection because, for example, um, um, the size of the incision that we had to have to insert the port, and on the same incision also the suction, for example, of the clip applier of laparoscopy should be at least 3 or 4 centimeters. So in case of major hepatectomy, I think it's more useful to use, for example, the Da Vinci XI because we have a larger field, we have more strong traction. So I think the position should be on minimal invasive surgery with the necessity to have a small resection. I don't know if in liver surgery, I think it would be an indication, maybe in some resection of the bile duct, because we imagine the field is small, and maybe in some distal pancreatectomy, and surely in urology. And for example, I think it's very interesting role in breast cancer because we have in our center a unit of robotic breast cancer, and it allow to have a 25 millimeter incision on the axillary line to perform the mastectomy. So from the point of view of what is the aesthetic advantage is very, very important. I think it could be a quite good indication in general surgery, but it should not be extremely revolutionary compared to XI. But anyway, the less invasive we are, the better it is for the patient. I can hear
Emre,
you.
your sound is turned on.
Also, there is one more question that what are the lesions that robotic liver surgery would especially recommend for beginners? Can simulations reduce the length, learning curve? What is it,
Yes,
learning curve and
yes.
to
I think
which
that it's very important the simulation part because it's like the when you learn driving, you have pedals, you have button, you have a lot of things that could be very good trained in simulation mode. After that, you have to carefully select the cases that you want to perform. Because I am Da Vinci proctor, and I go abroad a lot of time for starting program of liver surgery in Italy, and also in some cases I've been in Europe. I've traveled a lot, and I've seen that the center that start with this kind of activity that carefully select the increasing difficulty of cases continue the learning curve in good way. If you did not choose the good cases, you perform one case or two cases and then you stop due to conversion, the bleeding, and the complication of post-surgery. So very carefully select the first cases. I suggest small resection of anterolateral segments, left lateral sectionectomy, something that we can manage also in laparoscopy, could be translated. Do not start with major hepatectomy or Klatskin tumor or posterior superior segment. It should be an increase in increase the difficulty learning curve.
Okay, thank you. We have one more question regarding this topic, and it's the what are the key considerations for converting for you especially? Is there a time constriction or just bleeding? What are the main intraoperative incidents that you decide that you should convert?
So I think we should divide the kind of conversion. Okay, you have planned conversion and emergency conversion. So we speak about emergency conversion. In case you cannot manage bleeding, you have emergency conversion. And as we told before, all these kind of steps that allow you to have an emergency conversion to save a patient and to stop bleeding if you did not arrive to control by robot. But I think it's easier to control bleeding by robot. After that, we have planned conversion. I mean, during surgery, you have something that allow you to decide to have the conversion. The first one of planned conversion is the impossibility to achieve the correct resection margin. For example, if you want to perform a kind of surgery, did not arrive to have an R0 resection due to the position or something like that, you can plan your conversion. The second one is the fact that the operation is too long, because to perform segment 7 resection, it could be longer, but it could not be 20 hours operation to perform this by robotic. And this is another step. In our first experience in Whipple procedure, we told that if we did not have completed the demolitive phase at 3 p.m. or 4 p.m., we have conversion because it's of patient safety. This is another important thing. And the other thing is, for example, but it's not so common in patients that has just been operated for adherences. It could be another thing of conversion. We do not have a clear surgical fit, we can convert.
Okay, thank you. We don't have any more questions regarding this topic, so we can continue with the second topic. The second presentation will be the video-based comparison of laparoscopic and robotic techniques.
Yes. So I have just a second, I'm searching the presentation. If you had other question with the,
Yeah, okay.
we can have.
Okay, there is also one more question regarding the air embolism during conversion. Is there a particular maneuver that you would recommend to prevent air embolism?
We did not use air seal because of the fact that we have if you have a bleeding during the surgery, you can pump air in the vein, and it could have a sort of loss of possibility to do this kind of, uh, of control during surgery. So low preoperative medium, it would be very good, for example, to know to have at the beginning, and just clamp in case of bleeding. I think it's the best way to avoid. And in case you have a hole on a vein, that is one of the most important complications that can have of air volume. You have to speak with the anesthesiology and you have to try to stop the bleeding and the insufflation of air.
Okay,
So
thanks.
I have to share the video. Okay. So I think one of the most important things that we could have is to compare something that we know very well. And I think it would be a good idea to have to speak about left lateral sectionectomy. Then, if you want to see a more complex video, we can see. So, to identify which are the main differences between laparoscopic and minimally invasive surgery. So, the basic principle is the same because surgery is the same. So, we have segment 3 pedicle that is on the lower part of the with closer to our camera and segment 2 pedicle that we have to have during the kind of resection. So be always on the left part of the round ligament, 1 or 2 centimeters far along the falciform ligament to avoid injury either of the segment 4 branches, either of the middle hepatic vein. And we should be from the lower part inside 1 centimeter from the round ligament, and we have the correct plane of the left lateral sectionectomy. For the port placement in robotic surgery, as I told you before, camera is in the umbilicus part, 5 or 10 centimeters in the upper part. We have two assistants. We used to have two arms on the left part and one arm on the right. The tool that we used to have is either ultrasound, it's mandatory for me, Maryland, and fenestrated forceps, clip applier. In some cases, if we can have robotic staple or the vessel sealer of the synchro seal. So if we want to have a comparison of the two techniques I have here, we can have this video that explains us which is the difference. On the left part, we have the laparoscopic, the robotic approach. On the other part, we have the laparoscopic approach. The maneuver are similar. We have, as you can see, the Pringle maneuver that is extremely important either in robotic, either in laparoscopy. We used to perform and to prepare in both approaches. So we have the Pringle catheter, the urinary catheter in the robotic approach, and the intracorporeal Pringle maneuver prepared in laparoscopic approach. It's a little bit more complex, but no one avoid us the possibility to have the same Pringle maneuver. The intraoperative ultrasound is you can see the video?
Yes.
Okay. Because the ultrasound is mandatory. For example, this is one of the first cases that we had in robotic and in laparoscopy. The transection line is very, very important because you have the possibility to have with a vessel sealer, for example, in the robotic approach. Otherwise, we trace with bipolar forceps, as I told you before, it's just monopolar energy. And then we start to approach the pedicle of segment 3. So with the approach of the pedicle of segment 3, we have the double bipolar calculation technique. It's called the Mamba technique that we described. And we go crushing the technique, the parenchyma. We are going to identify the pedicle of segment 3. In laparoscopy, we use almost the same concept. You see in the lower part, the pedicle of segment 3. And we are going to have going around this pedicle. In robotic, it's more easier for the dissection. And after that, we can use either a stapler or the M-lock, for example, as we use in the robotic case. We clamp the pedicle of segment 3, then we move to the pedicle of segment 2. And so we go to encircle this pedicle with the dissector in the right part and with the Maryland in the left part in the robotic surgery. Then we go with the stapler. And for example, in laparoscopy, in that case, we perform another stapling line. Always we use to help us the tape of Vicryl in order that we can either clamp or staple on this one. In case we want to secure, we use a little bit of.
I think your presentation is. Can you share it again or? Yes, it's okay now.
Now it's okay. So we go back to where we was stop. This is the pedicle. As you can see, we go and we stapler the segment 3 pedicle. After that, we move to segment 2 pedicle. You see, we use the bipolar, double bipolar technique to identify this. And then in laparoscopy, we have a larger use of dissector that we don't have in robotic, but we have the the, the possibility to use some tools like the gold finger or something like that. We staple the pedicle of segment 2, and then we mobilize the left lever. As you can see, we use the synchrosil, for example, in robotic, or otherwise we can use the thunder bit in laparoscopic surgery in order to have the possibility to pass below the left lever and then go through and to have this kind of approach. As you can see, we work on the left hepatic vein. So we go on the parenchymal transection. We isolate the origin of the of the vein. In this case, we put something like the hemlock, and then in laparoscopic case, it's more easier, maybe due to the articulation, to use the stapler. So you see in comparison, we use maybe the same principle, but the possibility to perform by robotic is more easier, for example, in the dissection of the pedicle and in the isolation of the vein.
Thank you for your video also. What do you think?
A lot of if you just one thing. If you go on my YouTube channel, there is a lot of video of robotic surgery. So if you want, you can find for free a lot of them if you want to see something other.
Okay, thank you very much. What do you think
And also, just to say another thing, if you want to visit and come to visit us, you are invited in Italy and in Puglia. You are welcome. I will be very happy for this.
Thank you very much for your kind invitation also. And what do you think on the techniques, robotic or laparoscopics? Which is less minimal invasive actually?
I think it's similar. I think it's minimal invasive for complex cases, robotic surgery. Because I see some advantages in complex cases. Major hepatectomy, posterior segmentectomy, asking tumor. Uh, Today we perform a segment 1 resection that is close to the hepatic vein and vena cava. So I have an advantage, a technical advantage in a small field with the rotation of the tip of the instrument. But to arrive to do these cases, we have to had simple cases before, like left lateral, wedge resection, something like that. So when we arrive to be confident for major and complex cases, I think up to now the place for complex cases is robotic and easy cases should be performed by laparoscopy or single port. Yeah.
Okay. Also, what is your opinion about the patient side surgeon? How experienced should be the patient side surgeon? Do you
Should
think
be
that it's important, the experience of the patient side surgeon?
it's enormously important because it should be someone that is trained because you have some steps, especially when you have difficult cases that are very important, like suction or clip applying or exposition or during bleeding. It should be someone that know how to, for example, manage bleeding with you. Otherwise, you are alone. Also, if you have a robot, then it's complex. So it's very, very important to train also in the assistant, in the changing of tools, in the removing of tools. If someone should be trained to remove the right tool, not the wrong one. So it's because, for example, you can have a vein in one arm and you have to remove the other one. So it should be someone that is experienced.
Okay. Also, what do you think? What robotic surgery adds? Uh, for example, for operative time, or does it has any advantage on operative time or complications? What do you think?
Up to now not demonstrated, but I think we have a lower bleeding compared to laparoscopy because it's easier and a lower rate of R1 resection. All the rest should be similar. It's also four hole in the abdominal wall, so it's difficult to have better. But on the quality of surgery, I think we could have something improved.
Okay. Do you prefer liver hanging maneuver during right or left hepatectomy?
Not in robotic. In open surgery, yes.
Instead of this, what do
Robotic could be
you prefer?
difficult.
Yeah. In
I
robotic,
prefer anterior approach. So
okay.
we go, yeah, yeah.
Okay, thank you. And what is your opinion about the cost?
Cost is high, but it should be considered in the global cost of the hospitalization of a patient. If we arrive to discharge 2 days before, because of reduction of complication, it could be equal cost. But I think up to now, we should not see robotic now. We should be in 10 years. As you told before, with integration of AI, augmented reality, intraoperative guidance. If we will arrive, I think, one day to know exactly where we are going with all these tools that we were speaking about, we should reduce the intraoperative complication. It could be very, very important also in the reason of costs, because an intraoperative complication, a conversion, a bleeding have an impact on the length of hospitalization and so an impact of the cost of a surgical procedure.
Okay. There's also one more question regarding technique. Uh, do you present that you prefer double bipolar technique?
Yes.
So do you need CUSA during robotic surgery, or do you have any experience that patient side surgeon prefer use CUSA and it's
So
done robotic surgery?
it could be used. Some teams use this, but we learn to do not use, because in the place of the bedside assistant and of the port is blocked among the robotic arm. So if you have some straight line, like right hepatectomy, left hepatectomy, you can use. But if you have a non-anatomical segment 7, it's impossible to use CUSA. And so the best surgery which you need CUSA, it's complex cases, and you cannot use because it's difficult to use because you don't know where to put the CUSA. You cannot put something among the robotic arms. It should be always below, but straight line like in laparoscopy. So it's not very useful for me.
Okay. Also, there's a question that considering lateral segmentectomy, which technique do you prefer, robotic or laparoscopic?
In learning curve, robotic. When you don't need laparoscopy, but it's a very good training, a very good surgery for learning curve. But it could be very good. It's a case that could be performed safely in laparoscopy. I don't see the necessity of a robot for left lateral apart from learning how to use the robot.
Okay. Also, one more question that which robot do you use? I think DaVinci XI.
We have two XI and one SP.
Okay.
There is Hugo also in our hospital, but it's used by the urologist and gynecologist.
It's not allowed for liver surgery yet, I think, yeah?
No, no. We used for some gallbladder and some abdominal wall. But we prefer Da Vinci. We have a good experience in Da Vinci.
Also, as being an experienced liver surgeon, we wonder your opinions about what are the potential innovations for enhance the efficacy of robotic liver surgery for the future expectations, actually.
Augmented reality. I think it could be the game changer because uh, intra-abdominal intraoperative ultrasound. It's a, tool, both tool, but it's thing of last century. So we have to relapse with augmented reality. We have some experience in Strasbourg with the superposition of 3D reconstruction, but it's not so um, easily to use because the model did not move. Once that we will have this, the reduction of bleeding, for example, or lesion of bile duct, it will be reduced. I think very, very important.
Okay, thank you. I think we have answered all questions from YouTube and Zoom also. There is no more questions. Thank you, Professor Ricardo Momeo. We kept you busy, but it was a great presentation and question and answer session. I am sure that it was beneficial for the audience, and thank you very much.
Thank you very much. You can contact me whenever you want for any other question, or if you want to speak about a little bit of robotic, or as I told you before, if you can visit me, it's a pleasure.
Before closing the session, as the president of the society, I would like to thank you once again for your accepting our invitation and also for your invaluable scientific contribution to our society. I would like to share the statistics of this webinar. During the webinar, almost 60% watched from a YouTube platform, official YouTube platform, and also more than 20 people in Zoom platform. We keep the record in our official YouTube channel. That means in the near future, much more people will watch and benefit the contents. Thank you once again.
Very nice.
Have a good night.
Thank you. Bye bye.
Bye.
Thank you. Bye.